WFJA 105.5, Sanford, Pinehurst, Southern Pines.
It's now time for the Recovery Boys, Lewis Finch and Macon Moy, as they spend the next hour with you discussing the issues of alcoholism and drug addiction, as well as the road to recovery. Here's Lewis and Macon.
So good evening, everybody. Show 3 for us. I'm Macon.
I'm Lewis.
And we're the Recovery Boys. We're excited about the show tonight. We've enjoyed our conversation. We always maybe get together and have a little dinner before the show, and we did it again tonight. We have a wonderful guest tonight who's actually going to be in studio with us, and we'll introduce him in just a few minutes. But Lewis, I enjoyed the show last week.
It was nice. We had last week, if you remember, we had Bob Marrier, interventionist to the stars, and he was very informative. In fact, we were just talking. He'd probably still be talking had we not had to cut him off at the 3-minute mark before he left.
Yeah, you know, it's funny. I saw our director flash 5 minutes, and he was still rolling hard, and I was worried that he was going to talk right over our end of our show, but he was very entertaining, and he obviously has lots of great information. The intervention is obviously the start of the recovery process. One of the things we want to do with this show is introduce our listening audience to all aspects of recovery, and the intervention is kind of the start of that. So I thought he did a really good job for us.
Well, Macon, think about this. For the first 2 weeks, we had 2 guests who refused to come into the studio. We now have somebody who has dared to come in. And our 2 guests were Thomas Hollywood Henderson and Bob Marrier. And now we have someone who's actually in the studio with us, which takes an incredible amount of fortitude, I think.
Yeah, and we'll bring him on in just a second. You know, as we promised, we're going to try and talk about different aspects of recovery, and the kind of the 2 subjects tonight, which our guest will weigh in on and give us some of his wisdom, are the relapse, which I'm sure if you're an addict or an alcoholic, relapse is something that you've probably experienced or certainly live with. If you're a family member, you probably found out about it in the worst possible way. But the other topic tonight is medicated assisted treatment. And that's really an interesting conversation. It's a little bit more of a sophisticated topic, but it's one that we want to introduce tonight because it's got, from a scientific perspective, I think that it's proven to become a very effective intervention for those of us that suffer from addiction and alcoholism. So we'll talk about those 2 subjects. Anything do you want to get off your mind before we get started tonight, Lewis?
Actually, when we discussed the topics for tonight, excuse me, I was thinking about my drinking and drugging career as I was driving in here, and I can't even say that I actually had a relapse. I don't think I ever really stopped. I ended up, I was one of those alcoholics that would, I would go to an AA meeting and then drive to the liquor store afterwards. I did that just to check the box for my wife because she was hounding me so bad. And upon reflection, I guess I wasted a good hour. I could have been drinking an hour earlier. So I don't know that I actually technically ever relapsed.
Yeah, I didn't have a relapse. One of the things my doctor told me when they finally escorted me out of the hospital after a lengthy stay is that I didn't have a relapse in me. That my relapse would land me at the morgue, and so that stuck with me. I want to thank the staff who delivered that message to me because it really stuck. But what is a relapse? A relapse is part of the recovery process. And I did some research on it, which I like to try and do before the show. And one of the studies I read would suggest that between 40 to 60% of people who've been treated for addiction or alcoholism relapse within the first year. And while relapse is most common during the first year of recovery, people with years of sobriety can resume self-destructive drug use or drinking. It's just, I think that some of the literature that we read, they call it a lurking notion that one day you might be able for chronic alcoholics, I mean, alcoholic like me, the lurking notion that one day I could drink like a normal person. And, one of the things you hear in some of the fellowships that we use to keep us sober is a day at a time. You hear that all the time, and it really is true for a lot of us. So the other topic, medicated assisted treatment, is the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. Research shows that a combination of medication and therapy can successfully treat these disorders. And for some people struggling with addiction, MAT, medicated assisted treatment, you'll hear it, MAT, from time to time tonight, it can help sustain recovery. And so it's something that there's a lot of opinion about.
Well, and I was going to say, when I got sober, I can't recall that term ever being used. I'm sure. Well, I know it was there because there were people on methadone or having taken methadone, but they didn't refer to it as, at least in my world, as medication-assisted treatment. In fact, in the circles, it was kind of taboo. And if you on the surface, it's kind of contrary to give an addict or an alcoholic a medication. But to me, the game has changed. When you read about and hear about all of the drug overdoses that are out there, any day you can keep somebody alive, one day at least, gives you an opportunity to get them the help they need. And I know there's some old school thinking out there that doesn't go along with that.
Yeah, well, I think that it's safe to say that the more enlightened people that work in the industry view it much differently. Sometimes you just need more time with the addict or the alcoholic, the addict especially where MAT is concerned. But anyway, we'll talk about that. So tonight, our guest is Dr. Jason Jerry, who's the medical director of the Behavioral Health Services Department of First Health Moore Regional Hospital over here in Pinehurst. And we had dinner with Dr. Jerry, and we had a wonderful conversation with him. I told him I wouldn't introduce him as one of the leading addictionologists in the country, but I'm going to do that anyway. Certainly one of the more respected addictionologists, and he's a wonderful resource for our community. We're very lucky to have someone with his education, his background, and his passion for what he does, and so we'll discuss that with him. So with that, I'll say, Dr. Jerry, and he said to call him Jason, but when we're on the show, I guess we'll call him Doctor to give us a little bit more credibility. Thank you for coming in, and welcome to the Recovery Boys.
Thank you, Macon, and thank you, Lewis, for having me on the show.
Absolutely.
Lewis, any questions to start off with for Dr. Jerry?
Yeah, I would like for him to kind of fill in the gaps. Give us some background. Give us his bio. I think it'd be interesting because I'm kind of blown away that, and I haven't even said this to you, Macon, but to me, an area like Sanford and Southern Pines and the Sand Hills area, to have someone of his caliber, I think is amazing. So I wish Dr. Jerry would kind of give us an idea of where he comes from.
So I initially got interested in addiction treatment in residency. I did my residency at a big county hospital down in Miami, where we serviced a lot of addiction-related stuff through our very busy ED, and also did a lot of detox down there. So that's where I really got interested in it. After I finished my residency, I started working at an addiction treatment center up in Palm Beach County, Florida, and also at the same time had opened up a private practice. And I soon began to realize after about a year that I really liked going to the addiction treatment center, but I didn't like going to my private practice, and so I made the decision to get out of private practice and devote my career entirely to addiction treatment. I became the corporate medical director of the watershed treatment programs in Palm Beach County, and was there for about 5 years, and then had the opportunity to go up north to the Cleveland Clinic. And I spent about 7 years there at their alcohol and drug recovery center. And came down here looking for a better place to raise my family in 2017.
Well, I can tell you that we're all the better for that decision. It's amazing that a hospital like Moore Regional can have that kind of talent on the floor, Lewis, as you talk about. Dr. Jerry, one of the things that you and I, or that all of us discussed at dinner was relapse. And, I'd love to hear your thoughts on the relapse process, but I also wanted to just I saw, I like to research our guests, and so I did see the shot of you on Oprah called Oprah Prime, and I thought it was very interesting. I was wondering if you could kind of describe how that came about and exactly, what that experience was like for you.
So that came about because after the death of Philip Seymour Hoffman via overdose, I got interviewed a lot in the wake of that, and Oprah picked up on something I had said in the New York Times about addiction tickling that pleasure pathway or tickling that circuit, I think I said, in your brain, and it, that it didn't really matter what substance it was, all of them have that final common pathway, but it was that tickling the circuit comment that she picked up on that piqued her interest, and her producers had reached out to me and asked if I would be willing to be on the show.
The relapse question that we kind of briefly went over, in your profession, relapse is something that I'm sure that you guys have to deal with. Exactly how do you address that with the patients that you work with?
I address it by looking at it not as a failure, but as a learning opportunity. I tell them, look, let's look at how we could strengthen your recovery plan and see what went wrong and what things went right before that. And let's see what we can do to tweak what you were doing so that you can, your recovery can be even stronger in the wake of this. So, no, I don't see it as a failure. I see it as a tremendous opportunity to really strengthen what you're doing and do recovery even better.
And what are the things that you tell if we got somebody out there who's struggling with a relapse, what are some of those conversations like? I know that I'm a recovering alcoholic, and I have guys that I work with, and it seems like the relapse is it's part and parcel of working with this population. But exactly how those conversations sometimes go with you?
Well, again, it's nothing to be ashamed of. A lot of them are ashamed to come back into treatment, feeling that it just failed. And I tell them, look, it's nothing to be ashamed of. It happens. You're not starting from square one. This isn't like the first time that you came into a treatment center where, you're starting at ground zero. You have a lot of solid recovery under your belt. And, obviously something happened leading up to this relapse. Let's take a look at that and see if we can dissect it, not to beat you up or make you feel, worse about it, but just to see what went wrong and see what we can change.
Lewis, at Wellwyn, and I know that you have a group of guys. Is that a problem at your center as well?
Well, it's interesting to hear his take on it. I deal a lot with residential programs because a lot of folks who come to us are just too acute. They're not a fit for day treatment, as we refer to it. I'm sure that's the same way with you guys at First Health as well, to some degree.
Yes.
So what I have seen from some residential treatment facilities is if they have patients, clients come in and relapse while they're in residential treatment, they will actually kick them out.
Yeah, and I think that's the wrong approach. I think you also see that a lot with medication-assisted treatment, where if somebody has a slip up, they get fired from the practice. And I can't think of any other area of medicine in which you do that. With diabetes, for instance, if your patient comes in with a blood sugar above 500 and they've been eating Twinkies, they don't fire them from their practice. So why do they do that with addictions? it makes no sense to me, in my opinion, when we're talking about medication-assisted treatment. If somebody slips up while in treatment, it's an opportunity to leverage what they're doing to get them into a higher level of treatment. Unfortunately, sometimes it's difficult to find those resources that will accept patients on medication-assisted treatment. But when you can do it, if you can bump them up from a day treatment program, let's say, into a residential program that will take them on that medication, it's an opportunity, I think, to really rein them in and again, get them on more solid footing in their recovery.
I'm glad to hear you say that, because our philosophy at Wellwyn is we actually use it as a teaching tool. We feel very important that it's actually an opportunity for them to learn. And we ask the questions, what happened? What was the impetus? What were you thinking prior to the relapse? Hopefully to get them to understand better who they are and what their underlying condition really is.
Right.
Well, I got to tell you, it's at dinner tonight we talked about the evolution and the amount of public awareness that the whole addiction, alcoholism has been around for as long as anybody can remember, but it was always kind of hidden. It was not one of those things that you discuss publicly. And if somebody in the family, I remember hearing stories about my grandfather needed to go away for a little while. It was never, alcoholism was never discussed, but everybody knew what it was. And so I think it's interesting, as we start to throw some of these terms around, the public awareness because of the opiate epidemic and how much coverage it's getting in the mainstream media has really made it, I think, a little bit more socially acceptable to have these conversations. But the amount of pure ignorance on the disease and the, proper, maybe proper is the wrong word, some of the more effective ways of addressing it are just now becoming known. Dr. Jerry, you've been in the business for a long time. What have you seen? Have you seen a much greater awareness amongst the society as a whole, where addiction and where alcoholism is concerned? Is it easier, do you think, today for people to talk about it than it was 20 years ago?
Oh, I definitely think that's the case. I think you'd be hard-pressed to find anybody in this country who hasn't heard of the opiate epidemic. So there is a lot of talk going around about that. And I think a lot of opinions have changed as well. I know I started my career in an abstinence-based treatment center. And as time went on, again, I got into medication-assisted treatment. Early on in my career, if I ever would have said anything about MAT, I would have been definitely ostracized, definitely fired from, my job in that. And I think a lot of that has changed. And now you're seeing even more residential treatment programs that are incorporating that into what they do. So I think a lot of opinions have changed over time, and I think a lot more people are talking about addictions than ever before.
If we were able to wave a magic wand and we were able to turn you into the opiate czar, one of the things that Lewis and I talked about is all the money. One of the things that you hear on mainstream media is this drug company is going to deliver this many billions of dollars. And everybody I think it's great for the conversation to take place, but everybody's kind of scratching their head. Where's all this money going to go? Do you, as a professional in the industry, have any kind of opinion about the best way to address this as a society?
Well, I have a couple. One is that I think there's this misnomer that, if your child, for instance, has a problem with addictions, the appropriate response is to send them off to a 28-day treatment program, and then they come home. And I think there's this, idea amongst family members that, they're going to come home and they're going to be cured. And nothing could be further from the truth. The work in many ways just begins when they get off that airplane and they're back home. And unfortunately, I don't think there are enough resources in each of the communities to continue that momentum that was started in a residential program. And there needs to be more of that, from, sober houses to, other resources, step downs to PHP or to day treatment programs and intensive outpatient programs, that sort of thing. I think that's one of the major things that's lacking around this country. I think also the one thing that has come up over the last 20 years or so is the evolution of drug courts, which is something that actually started in Miami, but now is present in many major metropolitan areas. I think it's a tremendous opportunity, probably one of the best things to happen in addiction treatment in the past 10 years at least, when you have that interface, when somebody addicted to drugs interfaces with the court system. Now you've got a tremendous carrot and stick approach that could get somebody the treatment that they need and turn things around rather than just be punitive. I wish we had more of that going on. I think down here we have 16 counties that have a drug court, but that's out of 100 counties. I think we need more of that. We need expansion of that.
One of the things we hope to do is we talked about it at dinner. The correction industry is probably does more work in the addiction and mental illness field than any other industry, and it's by default. It's certainly not by plan, and they certainly haven't been trained for it. But one of the things we hope to be able to do is to put the our local correction officials, the sheriffs of Moore County and Lee County, and police chiefs, and talk to them about that. But we probably need to reach out to the district attorneys as well and see if we can't get a drug court started in Moore County and Lee County. It would certainly. I've got a relationship with Judge David Watkins down in Augusta, Georgia, who runs the drug court for Augusta, and he speaks volumes about all the good things that come from that. The last thing you need to do is when you've had a DWI and it's the first offense, if you have a chance to make it a learning experience, your chance to really impact that person is pretty significant. If you just throw them in, I was actually took one of my guys that I work with. Took him. He called me. He calls me in the mornings and he called me and he had a court date. He had to go down to Carthage for court, and I told him I'd go with him. And I got to tell you something. You want to go down and entertain yourself one day? Go sit and watch the roll call at the local courthouse. It is unbelievable. But if you want to make a drug deal, I can pretty much tell you that's where you need to go because all the drug dealers are sitting there, And
Right.
he told me, he called me. It's funny. He called me after that and thanked me for going with him because that's a trigger for him to be in court and be around all those guys because, that's where there's a lot of guys there that aren't there for court, but there to make connections with some of the people. So, I think that's an excellent point. But those are local resources. The federal government's response has been a lot of conversation, but I'm not sure I've seen any policies coming out of Congress. Everybody talks about it always makes for an excellent press conference and to have a drug czar and all that stuff. But as I said at dinner, when's it going to float down to the guy who's in trouble? That local guy. There's a lot of money in addiction and in alcoholism. The treatment industry is a huge industry, but most of the people who need it can't afford it.
Right. And we see a lot of that. So, we do quite a bit of detox at Moore Regional, and hooking unfunded patients up with addiction treatment after that is a really difficult thing. Fortunately, in this state, we have a lot of faith-based programs that will take people without funding and without insurance. But then what? Then what? Who's going to pay for the halfway houses that they need to be in after they finish that acute phase of treatment? Who's going to pay for anything like medication-assisted treatment? Even if you go to the methadone clinics, there's still a daily fee that very few people who don't have insurance can afford. So those are a lot of the issues that I think we need to address. And no, that money is not filtering down to those folks.
Well, it's you get a guy coming out of jail or coming out of treatment with no resources. We talk about it all the time. A safe place to live, a job and a ride to work seems fundamental, but you have no idea what a challenge that is for this population. The treatment centers, the 28-day programs, those are just the start of the process. That's by no means do you get fixed. Sobriety is not something that you can purchase at the convenience store. It's a long-term process, and we just don't have enough resources in place for people who really need it.
Well, you guys were talking earlier about the guilt and shame factor that goes along with this, and it's amazing to me. I was chatting. I actually had a local rep with Hazel and Betty Ford in my office yesterday, and I was talking with them about where their brand has gone. I mean, if you think about it, that's probably the #1 brand in the field. Certainly Betty Ford's name. Hazelden maybe a tad behind it, but they're pretty much on equal par. And yet we're still talking about guilt and shame in 2019 over, as Dr. Jerry said, an illness that if you just transferred the word addiction to cancer or diabetes, it flips the switch.
I couldn't agree with you more, Lewis, and I bring up that point pretty frequently when dealing with my medical colleagues who, point a finger at addiction and treat it in some way differently than other disease entities. For instance, I've been in some circles where, cardiothoracic surgeons, for instance, will refuse to operate on an addicted individual with an infected heart valve, which is something that's not altogether uncommon amongst opioid injecting folks. And it's really ridiculous when you think about it. Are they going to apply that to the rest of their population who are clogging their arteries with bad diet and bad exercise habits? Are they going to make them, sign contracts saying that, they will participate in Weight Watchers and go to the gym 3 times a week before they do that, that bypass? Why do you mandate that addicts would sign such an agreement saying that they would go to treatment after they're done? It's not that I'm opposed to treatment after an operation like that. I'm a proponent of that, obviously, but it's just not consistent with the way that they treat the rest of their patients. And then the other issue is that you're forcing people to sign contracts that often they can't adhere to because there just aren't the resources out there. You get somebody that's flown in from rural West Virginia for such an operation. When they go home, they might be hard-pressed to find an AA meeting within a 30-mile radius of them, let alone a formal addiction treatment center.
Well, and also, I think we touched on it, but, from the relapse standpoint, you hear things out of people's mouths that still, to this day, blow me away. You'll hear consistently, when someone relapses, they just don't want it bad enough. How many of us have heard that?
Oh, yeah.
Or the better one that I really love is they're not working an honest program. Well, if you understand what addiction is, with a brain disorder, you can just cut it off right there. You're not dealing with someone that has all their faculties at this point.
Well, Dr. Jerry brought up a good point. It's a disease, and the relapse. If cancer comes back, everybody feels sorry for you. But if you relapse and you're an alcoholic or a drug addict, everybody thinks that you're weak and that you just don't want it, as you said, just don't want it bad enough. But I had one of my guys, and I wish I could have recorded it because he relapsed and he called me and he was crying and he said, "Why do I keep doing this?" And he was asking a genuine question. He doesn't know why. He just knows that all of a sudden there was a needle in his arm again, and you know what? He didn't want it. And so, I think that we talk about it all the time. I know for me personally, and for a lot of the guys that I talk to, the only agent of change is pain. I mean, that's what is required sometimes. And when you have that conversation with people who aren't sick, or not, if they don't understand or respect that it's a disease, they just don't. That you're just wasting your time. But it doesn't help that population of people. Treatment is so important. It is so important. Interventions are important. Detox is important. But you know what? We don't spend enough time. Certainly don't have the resources for aftercare, and that's where it's so needed. These guys and women. You come out of treatment and you've got this, they call it the pink cloud of sobriety, and you're so excited. And then all of a sudden you're treated with indifference. and all of a sudden, that just takes that pink cloud and that pink balloon and it blows it up. And so, I'm starting to see more and more. I've got some guys in Pinehurst who have agreed to give some of the guys that I work with jobs, and you can't imagine how happy and excited these guys are to have a job and a ride to work. That doesn't sound like a big deal, but I'm going to tell you something. Give it to somebody who doesn't have it, and they are so appreciative. And so, you're right. I think that resources, lack of resources, there needs to be more conversations like the one we're having tonight, to expose everybody to the fact that this is not a moral shortcoming, it goes across the board in terms of socioeconomic levels, race. There's an alcoholic or there's a drug addict represented in almost any population that you're going to talk to. And so I think that if we can do more to expose the disease for what it is and to try and treat it with some attention, as opposed to just acting like they're bad people. And I think that society has done that for a long time, and I think that we're seeing that turn somewhat.
Dr. Jerry, I wanted to ask you, because I think you see this epidemic on a much higher level than either Macon or I because of your medical background. But I'm curious, we talked about this a little bit at dinner about extended treatment. I see so many people who come out of treatment thinking that that's it, as if there's an end game to this. And I think we all know that's just really the beginning.
It's a lifelong project, as you well know. From that point forward, they're going to have to do something a little different every day than other people who don't have this disease have to do. If you're not keeping it in remission by doing the right things, that monster's going to reawaken and come back and push you in the wrong direction.
Well, my understanding is that there are roughly, from a treatment standpoint, 6 6 areas of treatment, beginning with detox. Then you go to inpatient residential. I kind of combine the two, but maybe I'm wrong on that. So inpatient residential, which is where you're sleeping in someone else's bed, eating their food while you're stabilizing and getting some good help. And that could be anywhere from, so detox would last anywhere from, a day, 2 days to 10 days, depending on the drug of choice?
Well, yeah. Typically alcohol, 3 days or so. With opiates, 4 or 5 days if you're detoxing them. And a lot of times folks come in for quote-unquote detox, but really what they're looking for is to get stabilized on something like Suboxone and then sent to medication-assisted treatment.
But then you've got the residential inpatient component, which could last up to, 90 to 120 days in some cases, right?
Some cases longer than that.
Yeah.
You look at Teen and Adult Challenge, that program's over a year, and they're not alone. There are other programs that have that length of stay also.
And then you've got the partial hospitalization.
Sure.
Which is basically it's a step down. It's day treatment, but you're not doing a whole lot more than simply going to treatment and living and sleeping in your own bed. Is that right?
Yes. Yeah, I think that's pretty accurate.
And then you've got intensive outpatient, which is what Wellwind does, which is basically 3 or 4 days of outpatient therapy, plus an individual or family session. And by the way, we haven't even touched on that yet, the family part. And then you've got outpatient, which is a step down from that. And then you've got individual therapy.
Well, and the piece that we're leaving out, and perhaps the most essential piece, is the 12-step program.
Mm-hmm.
It's really not all about formal treatment. Let's face it. Back in the early days of AA, they were, Bill and Dr. Bob were lucky if they could get alcoholics into St. Thomas Hospital for a few days to dry them out before getting them into meetings. So it's not always been about residential treatment and flying out to California or Florida for that acute phase, but meetings work. The big book works if you live it, and I really think that's the most important piece. Now, obviously, residential treatment and day treatment and intensive outpatient programs help jumpstart the process and get people immersed into the 12 steps, if you will. But that's not the end-all, be-all.
Well, and it's a good point you bring up. So my discharge plan when I left my treatment center was go to 90 meetings in 90 days, get a sponsor, and work the steps.
Right.
And for the majority of the people who left that center, that was their aftercare plan, which is a very good plan, but you've got to work it.
Right.
It's an action plan.
Yep. Yeah, I've met plenty of people who have the big book memorized, but failed to live it out, and wonder why they, land back in treatment.
Well, it's so important to have some plan. I know that when for Dr. Jerry's for more regional, they make sure that there's a plan in place. But as you guys bring up, and it's so important to remember, is a plan is only a plan. If you don't execute it, you end up right back where you started. And Dr. Jerry, I was wondering, how do you guys at the hospital? You must see the same people over and over again. Is there a policy? Do you ever give up on somebody? Is there a time where it's hard to let them back in to
Absolutely
do the same
not.
thing?
Absolutely not. And again, I'll go back to other disease models. You have, diabetics repeatedly coming into the emergency room who obviously weren't adhering to appropriate diet and, taking of their medication. The compliance rate, last time I looked at it, the compliance rate with medications for diabetics, for instance, was about 60%. So, again, we don't come down on people in with other diseases in the same way that we do with addictions. And I treat addictions like I treat any other disease. It's not a failure. And, we do see some repeat customers, but again, it's an opportunity to do something different. Where did things go wrong the last time you came through here, and what can we do different?
Yeah, and it can be, if it's handled properly, it can be a learning experience. And you know what? Sometimes it takes people a lot longer. Some people get it the first time, some people get it the 15th time. But the most important thing is that they still get the same opportunity over and over again. And this, unfortunately, society doesn't really deliver that opportunity a lot of times. And you see some of these folks, and they already, just speaking from personal experience, they already feel horrible about what they're doing.
Right.
It is out of body sometimes. You do find yourself looking at yourself doing it like, what am I doing?
Right. And people look at it like it shouldn't be something that's expected. But, really, if you look at one of the addictions that we very seldom talk about, but, probably should discuss more, smoking. How many people ever are successful in their first quit attempt?
Hardly ever.
Right. And, again, it's only through repeated attempts that people ever get off of cigarettes. So why should we be so surprised that it's not the same with, heroin, alcohol, or any other substance of abuse?
Well, it is. I will say that I think that it's getting to be, it's becoming better known, and maybe people are starting to be treated a little bit differently. We certainly hope so. It's so important that people seek help, and if they feel judged, sometimes they'll keep them away from the help they so desperately need. And there's a lot of people that end up dying from this disease. We all know somebody that's been through that, and it's a horrible thing. Before we run out of time, Dr. Jerry, I would like your view on medicated assisted treatment.
Well, I think, as I said before, my opinion on that has changed dramatically over the years, initially starting in an abstinence-based program and being told that, basically Suboxone and methadone were the devil. I began to see over time that I lost a lot of patients. We would get these folks that would fly down from, various parts of the country for their 28-day treatment program, and oftentimes would then transition into halfway houses in the area down there. And I can't tell you how many times that I heard that, so-and-so that I treated a couple months before was, found dead in that. And it really, it was tragic. It was disheartening. And again, I began thinking, wow, if that guy had only had another chance at treatment, perhaps that would have been the one time that he got into long-term recovery. And so my opinion changed. It changed over time, and I began to realize and to look at the statistics on abstinence-based treatment. And really, if you look at studies that going back to the 30s, only 10 to 20% of patients who enter into an abstinence-based program are able to achieve long-term recovery. It's not to say that they shouldn't try, or that I would discourage anybody from pursuing that, but I think the ones that do pursue that need to go into it with their eyes wide open. But for others, being on Suboxone or methadone can be a lifesaver and can keep them around long enough until they see the light of recovery and get on solid footing.
Can you actually stay on it for the rest of your life if you needed to?
You could, absolutely.
Are the people able to function as fairly normal?
When I was up north and teaching residents and medical students, and they would come to spend time with me in the outpatient clinic, I would tell them to take a look at my waiting room and to tell me how it looks any different from any other waiting room throughout the hospital. Because it doesn't. I mean, the folks that I had in there represented, every, level of society, and PTA moms to corporate executives to doctors to you name it. This doesn't spare anyone. And so, it's, I don't know what more to say about that, but.
What's the longest you've ever known anybody to actually be on one of the?
I had some folks that were on it from the moment that I came to the Cleveland Clinic until the moment I left, so almost 7 years.
So it is possible to be a functioning member of society and be on it, right?
Absolutely. Yeah,
Okay.
absolutely.
But I think there's a misconception out there that no, you have to be working towards abstinence necessarily, or you've failed. Again, another shame and guilt thing thrown at you.
No, and I've had a lot of people that were functioning well, working a solid program, and at some point said, "Hey, Doc, I'm going to several more meetings a week than what you're asking me to do, and not only do I have a sponsor, but I have 3 sponsees. Can we talk about starting to taper down?" And I'll do that with them, and for some of them, it doesn't end with them getting off it completely, but we get down to 2 milligrams or so, and they say, "You know what? Let's stop here." Not because I'm experiencing any withdrawal, but just because I feel good at this dose. And so we stay there. But the one thing that's clear is that when patients decide when they want to come off, they have better outcomes. If doctors say, "Hey, you know what? It's your 1 year is up. It's time to get off of this stuff," that never works.
Well, let me ask you this question: the cost. How much of your success or challenge is controlled now by the insurance companies? Is it hard to get somebody on medicated assisted treatment? Will the insurance companies pay for that?
Yes, the insurance companies will pay for it. We don't really run into much difficulty there anymore. But it's, what do we do for all the unfunded folks? And again, it's not like the methadone clinics are free anymore. They all have a price. And so, it's just a real challenge with the unfunded folks.
I'm not sure how we're, as a society, ever going to be able to address all those things, because that population is underserved. And they suffer just as much as the ones with insurance.
Well, and it's really heart-wrenching, too, when you get somebody like that comes into the hospital because they have an infected heart valve or something like that that's, really serious. And, they spend 6 weeks in the hospital receiving IV antibiotics and that, and then you discharge them with nothing. I mean, they can't afford medication-assisted treatment. They have no resources. They're unfunded. Now what? These are folks that likely aren't going to live very long if they don't get into solid recovery.
Yeah, well, I think one of the things that I would hope, just me personally, is that a big chunk of this money would go into some kind of fund so that people without resources would have some access to services, because it's so needed. And it is those, as I've said a million times, those people without resources suffer just as much as those that do.
Right.
I do have one other question I wanted to ask you. We didn't talk about this at dinner. Is what are you seeing drug-wise coming through? Have you seen a change in the type of drugs that you see coming through that people are addicted to?
I have. I mean, when I first came down here, I was astounded to see the amount of opioid pain medications that were still being abused down here. When I had left Cleveland, everybody had pretty much transitioned over to heroin. It wasn't that way down here. Now I would say that more and more folks have transitioned to heroin. So heroin's the more common thing down here as opposed to pain medications. The other thing we're seeing a lot of now is a rise in methamphetamine. Methamphetamine has really started to surge around here.
So we really haven't done this yet, Macon. I'd like, since we do have a medical professional on our team now. You don't know that you're on the team now.
One of the best. One of the best in the country, by the way.
Can you explain to our listeners what heroin, what it looks like in the individual, and how it reacts with the body?
Well, so heroin stimulant. Well, I'm trying to think of how to say this in a sort of simplified fashion without getting too far into the weeds. Heroin. You want me to talk about what it looks like in withdrawal,
please. Or the whole? Because I think people have a misconception of it. They see what they see on the movies and on TV,
right?
And they don't see what the person is feeling when they're on it, and why it's so compelling to them.
Well, let me just give you an example. People talk about the self-medication idea that, people use drugs to self-medicate for something. If that's true in any area or with any drug, it's probably most true with opiates. I can't tell you the number of people that I see who report that they were, the kind of the shy, nervous type, and, all of a sudden somebody gave them an oxy at a party, and wow, it calmed them down. It took away all that anxiety, and now all of a sudden they could mix and mingle at parties in that. So I think that's just one example. But, oftentimes as a result of that, after we get them detoxed and that, we're dealing with a lot of anxiety issues and trying to help that with medications and that. But that's just an example in terms of kind of the feeling.
And when you get into, so they take the pill at a party once. And for those of us that are predisposed to addiction, the 15% or whatever the number is, how do they propel themselves? Because you hear about this all the time. I've had women come into our facility, one in particular who went in for a back operation, got addicted to opiates, ended up shooting heroin between her toes.
Right. So that's the most common progression. We see that all the time where somebody says, Doc, I injured my shoulder in a motor vehicle accident a few years ago, and the doctor started me on oxycodone, and after a month or so, I started to notice that I really liked the way it made me feel, and so I started running out of prescriptions early, and then the doctor cut me off for that reason. And I started obtaining it from friends, and then I got to the point where I said, why should I be spending $1 a milligram on oxycodone when I can get heroin at 1/10 of the price? And then, again, that's rationalized by saying, well, I'm just going to be snorting it rather. I'm not going to be shooting it. And then eventually they cross that line too and start injecting it. So, in a lot of ways, addiction is a disease of crossing lines that you never thought you'd cross in a million years. And it's not like, I think the misconception that, well, somebody walked into a party one night, saw somebody with a tourniquet around their arm shooting up in the corner and said, boy, that looks like fun. I think I want to go try that.
That's interesting because fortunately for me, I did not find heroin. I probably would have been a really good heroin addict, but I did find cocaine. And I use the example that I wasn't addicted to cocaine. I liked it because it kept me awake to drink more. And I somehow rationalized that in my head. I don't know.
Well, I think that we all can talk about when at some point, I know for me personally, I know at some point I quit using because I wanted to, and I started using because I had to. And you're talking about the line getting crossed, Dr. Jerry. I can't remember when it happened, but I can distinctly remember what it felt like. And all of a sudden, it wasn't a choice. It was a responsibility. And if I didn't live up to the responsibility from a use perspective, I paid the price. And for the addicts and the alcohol addicts especially, drug sick's a horrible thing. And
Right.
If you've ever been addicted, you know what I'm talking about. But it's medicated assisted treatment. If that can be a lifeline, to somebody to a better way of life, then I'm all for it. I just don't. I guess I struggle with people who would find. I hear the conversation, well, you just trading one drug for another, and I always marvel at that comment. I don't know how to respond to it.
Well, again, look at my waiting room. People aren't nodding off, in my waiting room as they would be if they were high. They're not getting high. We're dosing them appropriately so that they don't get high. And furthermore, Suboxone is not really like that in terms of, we hear about it on the streets a lot, but on the streets, it's not the drug that most people would, want to go after if they wanted to get high.
Right.
There are far better drugs out there that, could get one more high and be more pleasurable for the same price. But what people are using Suboxone for on the street typically is to self-treat. They don't have access to legitimate sources of addiction treatment, and they want to stay away from the needle. Or alternatively, they can't get a hold of their drug of choice, and so they resort to Suboxone just to tide them over until they find the quote-unquote good stuff.
Yeah.
So I have a question. It just reminded me of something. So from a procedural standpoint, if I'm on a MAT program, what does that look like in my life? How often am I coming to you, or am I coming to you?
It depends on the provider. Up front, initially, I like to see somebody start off in at least day treatment or intensive outpatient treatment in order for me to agree to take care of them, or be right out of a residential program and integrating back into the community, in which case I will also start them on that. But again, I think that medication-assisted treatment should be just one small part of a broad-based 12-step addiction treatment program.
So to reiterate, I would be coming to you once a day to get that, the Suboxone and methadone, whatever that might be.
No, when they're in that phase of treatment, like they're in a day treatment program, for instance, I would prescribe them for a week's supply.
I see.
They would be going to treatment every day except Saturday and Sunday. But in terms of the medication, I do 1 week prescriptions up front, and then eventually, as things progress and they transition out of intensive outpatient treatment, I'll space it out to once a month.
So you'd be monitoring them, even though you'd give them a week's supply.
Yes.
They'd be monitored along. That's awesome.
Be
Okay.
monitoring them, checking urine drug tests, looking at the state prescription drug monitoring program, and trying to keep close tabs on things.
Okay.
Dr. Jerry, and this is a much larger topic, but I did want to just throw it out there. We're starting to see more and more legalization of marijuana. I mean, marijuana is a step drug, not a step drug. I mean, everybody's got an opinion about it now because CBD this and CBD that. And I was just wondering, what's your personal view on marijuana?
Well, the CBD part I'll leave alone because CBD is not euphoric. It doesn't create a high. So, I don't have a real bad opinion of that, although I don't think it's the snake oil, the panacea for all diseases that it's being portrayed to be. With cannabis, look, I hear so much, and when we were going through legalization in Ohio, well, this isn't, it's not as bad as alcohol, and it's not like people overdose from it and that's the wrong way, I think, to look at it. I think we've developed this idea in our society that we have a right to numb our minds in some way and retreat from reality. And, it's almost like, well, we're gonna weigh out the options here. Well, if I'm not gonna get high on alcohol because, I might get a DUI or might develop liver disease in that, well, then why not marijuana? Well, what happened to living life by life's terms? And, it is possible actually to live life without altering your mind and just dealing with life as it is. So I think a lot of particularly adolescents have this idea that, well, I'm going to get high off of something, and let's take a look at what has the best side effect profile, if you will.
I can honestly say that I've met people and I'm significantly older than you, so you can take that for what it's worth. So the pot that I smoked in high school and in college doesn't exist anymore.
You're absolutely right.
It was, they wouldn't even, no one would light up a joint with what I smoked. The stuff that I've seen, and I actually was in a dispensary in Colorado not too long ago, because I'd never seen one before, and they actually had the THC levels written on the canisters, and there was one, I know that at least one that had over 30% THC in it.
Yeah.
And the stuff that I smoked, according to memory, was around 3%, 2%.
Right. Yep.
And having worked at a residential program for a period of time, we noticed that there was a group of people who would come in occasionally with signs of paranoia and claiming to be addicted to marijuana.
Right.
And that was totally contrary to everything I knew about the substance.
Yeah, no, it's definitely addictive, and that's, that, and it actually has a withdrawal syndrome too. But you're right, the more potent marijuana is leading more people to the emergency rooms for psychosis. We didn't really see that as nearly as much way back when, even 15 years ago or so. So yeah, it is becoming more problematic.
Unbelievable. Well, Dr. Jerry, we're almost out of time. There's one other quick question that I would love. Lewis's drug dealer calling mom.
It's worse. It's my wife.
Yeah, like I said. Besides drug courts, what other, for us, as we build this show out, what other local resources would you like to see in Moore County and in Lee County and just in North Carolina in general? I mean, anything else that you've seen that you would consider forward thinking that we could try and become an advocate for? Anything else you can think of?
We touched on this before. I'd like to see more opportunities for halfway houses and sober living options. The other thing, and we talked about this at dinner, was more resources for women who are pregnant and addicted. The response to those folks or the treatment for those folks doesn't involve detox. Detox is actually a rather dangerous thing to do while one is pregnant, and so the gold standard is to maintain them on methadone or buprenorphine until they deliver their baby, and then you can talk about other options. But we need more resources so that mothers don't feel shamed by their addiction and can get things on the right track while they're pregnant. And I can tell you, having had that experience with pregnant women, they were some of my best patients, some of my very best patients. They got to the point where they suddenly realized that it's not just about them and their recovery. They have somebody else dependent upon their recovery as well. And, a lot of them found long-lasting recovery after that experience.
That's certainly something that we will continue to talk about. We wanted to thank you so much for giving us an hour tonight to talk about this.
That's a great way to end this segment too.
Yeah, it is,
Yeah.
and I just want to make sure everybody understands how fortunate we are to have somebody of your caliber working in our community, and so we want to thank you for coming in, and we're glad that you think Southern Pines and Pinehurst is a good place to live. We did ask him at dinner if this was his final spot, and he said yep, so that's good news for all of us. So thank you for coming in.
And thank you very much for having me.
Well, Lewis,
Yes, sir.
end of show 3, any words of wisdom that you can close us out with?
No, I've said it all.
Well, what other topics coming up would you like to see us address?
Well, I think, and we've kind of broached them, or at least bounced around them. I think family, and Dr. Jerry touched on it. The people that we impact with our addictions, to me, we could talk about that ad nauseum.
Well, one of the things that we hope to be able to do is families, and I hear my wife remind people all the time, it's a family disease. I mean, the addict suffers, but the family's just as sick. And if the family doesn't get help, then the whole thing it can't work. And so I think it's really important that we do address that. Al-Anon, we've got some great Al-Anon in Southern Pines, and we can bring some of those folks on. But we will also bring on some families that have been impacted by this disease. And I think it's really important that we do that. So if you really like the show, go to therecoveryboys.com to our website, and the show will be posted by tomorrow. And we thank everybody for listening, and we'll talk to you next week.
You've been listening to The Recovery Boys on WFJA. Visit the Recovery Boys website at therecoveryboys.com. We thank you for listening to The Recovery Boys.